Bismillahirrahmanirrahim. Hi everyone. I'm sure many of you encounter some cases of abdominal pain where you've been like really scratching your head and wondering what's causing the patient's symptoms. Why this patient is coming to the hospital in and out with recurrent abdominal pain, or coming to see you with abdominal pain and abdominal bloating with GI symptoms, and all the basic workup, the history, the exam, basic labs, maybe even some abdominal images didn't really show anything. The patient is still having abdominal pain. It's a very common problem and it can be very difficult, and yes, sometimes you might not know the cause, but really my goal of this video is try to cover many of the common and less common causes, and maybe some of the causes that can be easily missed. But really my main goal is to try to have a frame for you and what would be probably the best way of clinically approaching patient with abdominal pain. So what we're going to do is first I'm going to talk about just common rules, or maybe like 6 steps to consider in mind when you're thinking about a patient with abdominal pain. And then we're going to talk about the common and less common causes by the abdominal quadrant. And then after that, we're going to talk about maybe having like a format or a way to approach abdominal pain when the abdominal imaging is not very specific, or didn't really give you the final diagnosis. Some of the less common causes and causes that might be easily missed by many of us. So let's get into it. So I would like to start with a case. This is actually a real case that we encountered a few weeks ago to demonstrate a patient coming with feature of sepsis and abdominal pain when the imaging wasn't really straightforward. So just think about it, and we're going to talk about it by the end of the video. I'm going to read it here quickly. So we had a 55-year-old male who does not speak English, with history of diabetes mellitus, presented to the emergency department with fever and rigors. Review symptoms revealed epigastric pain attributed by the patient and family to history of reflux. No prior abdominal surgery, no recent hospitalization. Vital signs included high temperature. He was febrile, but normal heart rate and blood pressure. He was hemodynamically stable. Examination revealed only mild epigastric tenderness, but otherwise no signs of peritonitis or alarming symptoms. Alarming signs, I mean. Labs showed leukocytosis, very high CRP, but normal ESR. Otherwise normal CBC and normal complete metabolic panel. Urine analysis was normal. Patient didn't have urinary symptoms anyways. Chest X-ray was normal. Patient didn't have any cardiopulmonary symptoms anyways. And CT scan was also normal. Ultrasound of the abdomen was done, and it showed mild gallbladder wall thickening, about 4 millimeters, but no stones, and they reported negative sonographic Murphy sign. A few hours later, the blood cultures came back, preliminary report showing gram-negative bacilli. And if you have watched my video about blood cultures, you know that gram-negative bacilli is likely a true bacteremia. It's not fake news. So now what? How do you approach this case? What's maybe the next workup to do? So think about it, and then we're gonna talk about it at the end of the video. So generally, I would say I will talk about 6 general rules to keep in mind while evaluating patient with abdominal pain, and of course the first one and second one are the most important, and of course you probably guessed it right: careful history and careful physical examination. Any patient with new onset abdominal pain really they need thorough evaluation with careful history and careful physical examination. I really cannot emphasize that more. Abdomen is the grave of the internist. This is a famous quote. Basically it means that it's very easy to miss many causes of abdominal pain if you don't really take a good history and do a good physical examination. It's very logical. It makes a lot of sense. There is a lot of structures in the abdominal cavity and surrounding the abdominal cavity that can give you abdominal pain, and without really careful history and examination you can easily miss them. So history and exam can provide diagnosis in up to 60% of cases, probably even more. Maybe the most important pivotal information I would say includes, of course, age and gender. As you can imagine, abdominal pain causes can be different in young patients compared to elderly. Um, and of course, there's different organs to consider between males and females that can be the origin of the abdominal pain. So keep that in mind. Location of the pain. We're going to talk about causes, common and uncommon causes of abdominal pain by quadrant. The classic example that sometimes this can be tricky is appendicitis. I always talk about appendicitis being the right lower quadrant, but as you know, it can also present with pain in different quadrant based on the location of the appendix. But again, that's less common. But generally, paying attention to the location of the pain is very important, and radiation as well. Time frame of the pain, that's really key. When did the pain start? How did it start when it started? Did it peak right away? Is it intermittent? Is it colicky? Does it come and goes? Did you have any prior episode similar pain in the past? Time frame, that's really key. Try to understand how the pain behaved before the patient presented to you. Associated symptoms, of course, is really key. Abdominal pain was predominantly diarrhea. Abdominal pain was predominantly nausea and vomiting. Abdominal pain was predominantly symptoms not related to the abdomen, maybe like chest pain or other symptoms suggesting that the source of the pain might be outside of the abdomen. So associated symptoms are very important. Risk factors for each pathology. If you're thinking vascular cause of the abdominal pain, the underlying pathology will be different between someone with risk factor for atherosclerosis, like elderly with diabetes and hypertension, compared to a young patient who without these risk factors. Then you think about maybe like aneurysm or congenital thrombophilia or something like that. So risk factors are very important. And physical examination, as you can imagine, again, also very key. 4 components of physical exam you need to pay attention to whenever you do abdominal examination. Inspection is the first one, probably one of the most important. Look at the contour of the abdomen. Is there any abdominal distension? Is there any scars? You would be surprised sometimes the patient might not provide you the full history, just simply because they forgot, for example. And then you do abdominal examination and you saw a scar, and then you ask the patient, hey, what is this scar from? And then, oh yeah, I had this abdominal surgery, a few years ago for this or for that. So that, it happened. So you might miss that if you do abdominal examination on top of the patient clothes. So be careful about that. I really highly encourage you to inspect the abdomen, especially in the first encounter in the hospital. Peristalsis, also sometimes you can visibly see it in patient with bowel obstruction, for example. Palpation, superficial palpation, deep palpation, start with the area that hurts the least, and then carefully examine the area that's probably hurt the most. And each one give you different information. We'll talk about that in a separate video. Percussion, there are different type of percussion, different maneuvers of percussion. Try to tease out if there's like a tympanic tone or the dull tone to your percussion note. Auscultation also, bowel movements, bruits. We'll talk about all that in one of the videos talking about abdominal examination. And at the end, never forget to examine the pelvis and the genitalia. Abdominal examination is never complete without examining the pelvis and or the genitalia. So that's really key. And as I said, I'm not going into details about abdominal examination here. I'm going to have a separate video about evidence-based abdominal examination and different ways that some different physicians do their abdominal exam. So stay tuned for that. The third rule pertains to severity. So be very careful. Severity can be really tricky. Very severe pain does not always mean catastrophic disease, and mild pain doesn't always mean benign disease. So for example, AAA rupture, abdominal aortic aneurysm rupture, obviously it's a very catastrophic, and patient usually present with very severe pain. Patient with kidney stones, if you have seen one, you know how severe it is and how bad it could be to patients. But unless the patient has one kidney and that kidney is obstructed, usually kidney stone doesn't give you have a catastrophic sequelae. But again, it can be really, really severe. Patient with cancer, unfortunately, they can have subtle symptoms, intermittent bloating, intermittent pain sometimes, and sometimes the patient might have ignored it for some time. But cancer is cancer; it's serious disease, so it can easily be missed if the assessing physician is not careful. And after viral infection and cough, it's very common to have like musculoskeletal pain in the upper abdomen. That's usually not very severe, and it goes away after some time. So it's a relatively benign cause of abdominal pain. So just be careful. You have to ask about severity, but don't be tricked by it. Next is the high-risk patients. These are the patients you need to pay a little bit more attention to because catastrophic causes can be easily missed compared to other patients, and they might not show you all the acute signs, concerning signs when they present to you. So these are the patients you need to pay a little bit more attention to. So imagine catastrophic abdominal emergencies may be associated with minimum or no detectable pain or muscle spasms in these patients. These obviously include seriously ill patients and ICU patients, and that's why they are in the ICU and they are seriously ill. That's quite obvious. Patients who are obtended or patient with dementia or psychiatric history or mental disorders. These patients you might not have the luxury to have really detailed history from, so you're missing an important part of making the diagnosis. And also their mental disorder can affect the way they present and can affect the pathology. So be careful with these patients. I have noticed that a lot of patients with language barrier, whom you need to use interpreter. I believe there's still, even with appropriate interpretation, there's still some communication issues and still some information that is missed between you and your patient in these patients. So pay a little bit more attention to them. And you might need to spend a little bit more time with them. I know sometimes it could be frustrating if you're busy, especially you're looking for the interpreter, you're waiting for the interpreter. It can take some time, but I have seen a lot of pathologies being missed, and I think part of that is because of the language barrier initially. Patients who are debilitated, for example, patient with malnutrition, these patients who look like chronically ill, they might not show you the acute signs of acute serious cause of abdominal pain. So they look chronically ill, so you might not pay attention to their acute presentation. So be careful with them. Obviously, pregnancy. Pregnant ladies, they can have really serious cause of abdominal pain without acute deterioration until late in the disease, and then they present real late and unfortunately serious condition. Also, you're limited in terms of investigations and imaging that you can do in these patients, so they're really high risk patients, so pay attention to them. Patients who are immunosuppressed for any reason, including patients who are taking steroids. Again, this patient also might not show you all the acute and florid signs and symptoms of a catastrophic cause of abdominal pain. So pay close attention to them. Morbid obesity, they might not also show you all the clear signs of peritonitis when there is peritonitis. And difficult abdominal examination is not uncommon in these patients, so you need to be careful with them. And patient with history of living against medical advice, or patient with high utilization of healthcare system, they're in and out of the hospital all the time, or being labeled as drug users, have such a history. I think there's some bias towards this patient, recognized and unrecognized, conscious or unconscious, but they still have the same or similar risk to the general population of having a serious cause of abdominal pain. So be aware of your own bias in these situations, and still pay attention to the symptoms and do the appropriate workup for this patient, without being biased by their background history. So these are the patients that you really need to pay a close attention to, because they can have really serious cause and can be easily missed. The fifth rule, and in line with what we just talked about, There are certain features that maybe you need to pay a little bit more attention to if you see them in your patient, because it might indicate a more serious underlying pathology. And these are really common sense. For example, hemodynamic instability, that's quite obvious. Signs of generalized peritonitis, and we talked about some of the patient population where signs of peritonitis might not be quite obvious on physical examination. For example, patient with morbid obesity, so you need to be more careful with that. We're going to talk about these sensitive and specific signs of peritonitis, and how to do appropriate examination for peritonitis, abdominal examination for peritonitis, when we talk about evidence-based abdominal examination in the next or in the following video. High fever is always concerning. Most of the causes of acute abdomen or abdominal pain are associated with low grade rather than high grade fever. So when you have a patient with a acute abdomen and high fever, that's concerning. Protracted vomiting, also concerning. It also has a major sequelae in terms of dehydration, acute kidney injury, and malnutrition and all that. Syncope or pre-syncope, it might indicate serious underlying problems, especially vascular problem. So when the patients say they have dizziness or lightheadedness or they're syncopized, take it seriously and evaluate the patient carefully. And of course, evidence of GI bleeding. Those of you who have seen a few cases of GI bleeding, they really can understand how serious that could be. Sometimes it's even like really quick, and a patient can develop into hemorrhagic shock really quickly. So if you have any suspicion of GI bleeding from history, patient had questionable melanoma, unexplained anemia, unexplained iron deficiency, they're coming with again pre-syncope or syncope, you have to think about occult GI bleeding if it's not quite evidence. But luckily most of the time it's obvious from history or examination that the patient might be suffering from gastrointestinal bleeding. The last rule is about investigation and imaging. As you know, you really need to pick up the initial test carefully after careful history and careful examination, number 1, and number 2 rules. And you don't need really CT scan in every single patient with abdominal pain or acute abdomen, right? In fact, about 2/3 of abdominal causes are usually caused by these pathologies: peptic ulcer disease, with or without complications, bowel ischemia, ischemic colitis, bowel obstruction, acute diverticulitis, acute appendicitis, acute pancreatitis, gastroenteritis, acute cholecystitis, or biliary colic. And probably the top 2 are the ones that you need emergent CT scan to evaluate the patient, to consider urgent or emergent surgery based on the situation. But for the rest of them, for example, in bowel obstruction, if the history suggested that diagnosis, you can do bedside ultrasound or Blaine abdominal X-ray KUB, and you can see the dilated loops, and then you start your treatment after that. If you're suspecting complications or masses or other mechanical obstruction, then you can get a CT scan to better evaluate the patient. In acute diverticulitis, if the patient is known to have diverticulosis, the guidelines actually suggest if they have classic presentation, you might actually start them empirically with antibiotics if there is no suspicion for complications. But with those without that history, you might need a CT scan, to make that diagnosis. Acute appendicitis also, if the patient has a classic presentation or suspicion is there, and you can do bedside ultrasound, and it might show you the diagnosis, then you can take them to surgery. But of course, CT scan also, if you're thinking about complication or the diagnosis is not clear, CT scan is very helpful in these situations. Acute gastroenteritis, the vast majority of acute gastroenteritis, you actually don't need imaging to make that diagnosis, and it's mostly supportive care. Only in few exceptions you need consider antibiotics and other invasive measures. Biliary system problems like acute cholecystitis and biliary colic, if the history suggested it, then you can start with ultrasound. It actually might be more informative than CT scan in many situations, so you don't need a CT scan unless there's more complications, so you want to look for other possibilities. So Again, sometimes simple images like ultrasound or X-ray might be more feasible and maybe easier to get and maybe the better initial test to consider. But the CT scan, also sometimes even MRI, will be needed in few cases to make appropriate diagnosis. All right, back to the case. Since we are done with the 6 general rules for acute abdominal or abdominal pain. So if you remember, this patient came in with feature sepsis. He had epigastric pain with mild epigastric tenderness, but he had fever, leukocytosis, high CRP. So and then the blood culture came back for positive for gram-negative bacilli or gram-negative rods. So it's very appropriate to get more detailed imaging in this patient, including CT scan, but it didn't show any acute pathology per the radiologist report. So if you also remember, this patient had it doesn't speak English language, barrier is an issue. The history is not really classic for any particular pathology, but because the pain was mostly in the upper abdomen, and the patient had gram-negative bacilli, it makes sense to think about common pathologies in that area that actually might not show up in the CT scan, and especially given the fact that the ultrasound showed a little bit of something. The gallbladder wall thickening was mildly, barely more increased. Normally it's 3 millimeters or less, but it's 4 millimeters. Although there is no stones shown ultrasound, but because of that, we decided to consider imaging for possible biliary disease, common cause of upper abdominal pain. And guidelines suggest that if you're suspecting biliary problem, acute cholecystitis, for example, you can get MRI, or you can consider hydroscan, and that's a test that we decided to go with. So we ordered a hydroscan, and it didn't. It showed that there is obstruction of the biliary cyst, suggesting acute cholecystitis. So we called general surgery. Patient underwent an eventful laparoscopic cholecystectomy, and intraoperative findings showed acute cholecystitis, which was also confirmed by the final pathology report. So it was kind of interesting case. It also showed how ultrasound can sometimes be a little bit more helpful than CT scan in some situations. We'll talk about that when we briefly talk about the abdominal pain in different quadrants, including the biliary system in the right upper quadrant. So thank you, and we'll see you in the next video. Thank you very much. Have a nice rest of the day.